to report out. Good to see you all here this lunchtime. Thanks for making the time. We've got some really good stuff on today and want to do justice to it, so let's get into it. First of all, we've got Critical Care and Neurosciences Value Stream RPIW 5, 4 hours or less. And I think we've certainly got Steve and Katie. Anyone else? Just you two? Come on down.
How are we going to work this now? Morning. Welcome. My name's Steve King. I'm process owner for RPIW 5, 4 hours or less for critical care and neurosciences. This RPIW basically focuses on looking back at all the other RPIWs we've done in the value stream and evaluating where we were and trying to pick themes and areas we could improve. So this all started with a time-out day where staff from across the two CSUs were actually gathered together to give their ideas, and this is basically what we came up with through the first 3 RPIWs. So we wanted to address the inconsistencies in the population of an ICU summary in EDAM. This was designed to speed up initially the EDAM process, and when we first did that, we asked the neurosurgical SHOs to do it, but unfortunately all that did was shift the workload from on the ward to do it on our HDU. So critical care said we'll take that up. So what we've done with that is we've effectively introduced a clinical summary which is updated day to day through the PPM, and this directly feeds into the EDAN. So the idea is the SHOs or the junior doctors who are doing the EDANs can just look at that on PPM and all the information is there without trawling through thousands of notes to find the information. We initially in RPIW2 looked at patient flow, and that was around providing information for the wards and for the flow teams early on in the day prior to DOP so they could factor in our step downs into the daily work plan. When we looked at that, there was some areas where we thought we could improve, and it was more around what the patient's needs were, and also switching from ticking the medically fit for discharge box, which I believe upset lots of people high up in the trust because it was confusing them, to go into a traffic light system. So we've introduced an amber-green system.
We're easily confused.
So we've introduced that effectively, and things I think are better. I'm not getting any rumblings from anybody. So, and RPIW3 was the ward rounds, which was a standardised embedded introduction to all patients on the ward round, what the content would be, and make that standard. And I think most of all increased direct patient contact with the consultants, because we felt that was quite poor really. And obviously the use of hello, my name is, and allocated job roles, so all the patients knew who they were dealing with. So I'm just going to briefly talk about the critical care input, and I think we've had it slightly easier than Katie, because we've looked at sort of system-based stuff, so that the PPM system, which obviously is a lot easier to manage than people are, so we did quite well there. So what we've done, the benefits of what we're doing was that we can have a live update on the critical care summary, and I'll show you a slide of that in a minute, but we found when we did that it wasn't only benefiting the wards and the SHOs, but it was actually benefiting critical care. It became a good tool on ward rounds to see the clinical progress, what investigations were done, without scrolling through lots of different parts of the PPM. So that really sort of drove it forward, and it's become quite embedded very quickly. The other aim of it was obviously to reduce the workload of the neurosurgical team when doing the EDAMs, saving some time. And it was to inform the patient flow teams, ward rounds and nursing handover about the patient's needs, i.e. whether they need enhanced care or they had tracheostomies, and obviously eliminate confusion over the trust overload discharge position. So this is what we did, and obviously I've not opened this for obvious reasons, but the clinical summary page, there's headings within that section, and as you open it, them headings reflect exactly what's on the EDAN system. So the doctors can quite pick out the information from the relevant systems quite easily. That can be opened on the ward round every morning. All the clinicians can look at it and update it as they see fit, and the nurses, if a patient goes for any major investigations, they will do it as well. So that has worked out really well, and I think from the registrar's point of view, it just seems to be common practice now. And even if we go to another intensive care unit outside the value stream, i.e. general particularly, you see the registrars in there updating this, which is quite surprising really, because we didn't really ask them to do it. So what we've done just to evaluate that was myself was look at that on a day-to-day basis. It's very difficult to go through all these patients and say that information is up to date 100%, and has to go around and find out, look for exactly what's gone on. But what I can say is every single patient, 94% at 60 days had that when I reviewed it, and at 90 days it was 100%. So that was really good. The level of care amber green update, that has just been 100% all the time. That's been really good, and I think that's because we initially introduced in the RPIW2 a similar system which just needed a slight tweak. So it wasn't a major shift for people when they were doing it. Okay. So what we want to do also is just look back, because we're reviewing so many of the RPIWs. We just wanted to look back over a period of time to see, have we made any improvements. So we thought, well, a good period would be 12 months. So we've looked, over 12 months is 5 quarters. So we've gone back to May last year, and if you can see from this chart, initially step downs of patients that were staying on areas on critical care for over 24 hours was up at 24-25%. It has gradually come down over the quarters, apart from a little blip around December, February, middle of winter, and we all know what pressures we have then, and then it's dropped again dramatically. And now we're looking at 14% of patients. So there's been a 10% increase over improvements over the year. The step downs within 4 hours, which is obviously what was our aim beginning of this, a very, very difficult target to achieve, I would say. But even over the year, we can see that patients who are being stepped down within 4 hours is improving. So it's from 12% up now to 17%. So there's been a 5% improvement in the year of patients that are getting out of neurocritical care within 4 hours. So we're quite pleased with that result, aren't we?
Yeah.
What else have we got? Oh, I'll hand you over.
As Steve,
Push the button.
thank you. As Steve has mentioned, one of the aspects that we looked at within this RPIW was ward rounds, and we were focusing particularly on patient interaction and introductions. The aim of this was to empower the patients to be more involved in their care, and the strategy that we took for this was to allocate people specific roles on the ward round. So one person would be in charge of the documentation of the ward round, one person would be doing the checks of the bloods, the obs, all stuff like that, and there would be one person identified to be the lead communicator with the patient. That was generally given to the registrar. So if we look at the data before the RPIW, patients were getting 66 seconds of direct interaction with the people that were on the ward round. Immediately after, we saw a really massive increase in this. It was a 103% increase from the baseline. At 30 days, that was 173%, so it was even better. At 60 days and 90 days, we've seen a little bit of a reduction to 88 seconds and 97 seconds, but overall that is still an increase from the baseline. And I think what's worth noting is that at the 30-day mark, we saw some knock-on effects of that increased time. So with it being 180 seconds, that then increased the length of the ward round, and by increasing the length, that then meant that we couldn't start the EDANs until a little bit later on. So overall, it has been a good improvement. So with regards to the introductions, prior to the RPIW, only 4 patients out of 94 received an introduction, which is around about 4%. Immediately after, we saw a 93% of people getting introductions, 30 days 74, 60 was 80, and 90 was 76. And the reason that we were really kind of having a push and a focus on people using the hello, my name is and introducing themselves is because we felt that if that's how the interaction was started, it automatically meant that the patient was then engaged in the conversation and engaged in what was happening next for their care. I think what we've seen is we've seen quite a natural peak immediately after the RPIW, and then it's kind of slowed down a little bit. But I think it doesn't mean that the momentum stopped. I think it's just that we're working with what we can do within the time frame that we've got and on the ward. So I think this is a more realistic way of how we're going to be moving forward. I think we've still got improvements that we want to make. Ideally, we do want it to be 100% for the introductions, but when I've looked into the reasons why, it's because people have often fed back that it's because they already know the patient really, really well. And I think obviously we can make allowances for that. Initially, we did do some work around how we could improve that, because we understood that people would feel a little bit uncomfortable going to people every single day and saying, hello, my name is. So we've given them ideas of using the phrase, I know we met yesterday, but if you don't remember, my name is so-and-so. And they have been using that, and rather than just introducing themselves, they've been introducing the whole team. So it's a team effort to it, and there has been a really good improvement. Moving on to EDAM production. So as I mentioned, the initial 30-day stage saw a knock-on effect on the EDAM production, because our initial target that was set at the beginning of this RPIW was to have one EDAN validated and authorised before 10 a.m. Initially we saw that there was a reduction in that, but that was because the ward rounds were taking longer and they weren't finishing till 10 o'clock. What we've seen is that it's been really difficult to monitor this actually, and the measures that we've been using have changed. So initially we were asking the medics to reconciliate medications for discharge, and we were hoping that by doing that, the medications would be able to be prepared simultaneously to the doctor then writing the clinical summary for the EDAN, just to try and save on a bit of time. We found out from pharmacists that this was actually causing more problems, so we've had to stop doing that. So we've had to revert back to the doctors doing the full EDAN and authorising it prior to it then going to pharmacy. So that's meant that they have been started a little bit later and gone to pharmacy a little bit later than the 10 o'clock, but overall we've seen a really big shift. So this was before the RPIW, and you can see that EDANs were only being initiated between about 3 and 6:30 p.m. And this is an amalgamation of the 60 and 90-day data. They're now being started at between 8:40 and 1:30 p.m, which is massive. So although we've not hit the target of one before, not all of them being before 10 a.m, there's a massive shift. And what we've seen is that if there's any complications with the EDAN, if there's any problems that pharmacy need to rectify, they can do that in a more timely manner so that the patient can then be discharged earlier. So this is our newspaper. So we initially had 10 items on the newspaper, and 5 of them have been completed, and we've managed to remove them from the newspaper altogether. There's still a few that we're looking at and ongoing at the moment. So that's the introductions to ward round. That's at 76%. Like I said, we would ideally like to get that to 100. Pharmacists tracking information to correct medications for discharge. That's ongoing, and it's also changed slightly. As I said, we've changed the way in that we're doing the EDAN, so we're kind of re-looking at how we're measuring that. So the time on ward round does not all add value to the patient. So that's at 77%. So I mentioned about the direct contact time that they're having on ward round, and that is 70% of the whole consultation lead time, which I think is a massive improvement. Initially it was 47%, so they are having more value added time. I mean, obviously there is some times where we need to look at stuff on the computer as a group, but I think that we have made a lot of progress with that. And then another thing that we've been looking at was the status of patients with regards to their antiplatelets. So we are still ongoing with that. We're trying to ask the medics to document that in the clinical summary at the same time, so that it's easily visible and they're not having to go into the EMEDS chart on ward round. That is variable at the moment, but so we haven't got specific data for that, but it is improving. And looking at the BTE column, it mostly green ticks now. And then the last one was the registrars leading the ward round do not appear to have enough time. We've looked into this, and there seems to be lots of different reasons affecting it. Often it's that they're in clinics, or they're on the acute list for theatres, and so the amount of time that they actually have allocated into their day to do the ward round varies massively. Moving forward, we're setting up a ward round working group which is involving the registrars, consultants and nursing staff, so that this doesn't just stop here and that we continue to improve it. And finally, this is our target progress report. It just goes through, we've already mentioned all of the things that are on here, but the lead time from decision to step down to them actually arriving on the ward has been 22% increase overall. So the EDANs, like I said, this is a defect measure of EDANs that are not validated before 10 a.m. It says minus 20%, but I think we can see from the data, although it's not a positive number there has been a massive shift and a massive improvement. The number of times ward round don't introduce themselves, that's a 93% increase overall. And then we've also had a quality measure of a number of colleagues saying that they can make improvements happen. That's an 83% increase overall, so that was great. One of the other things that we did a 5S on was the clinical summary, wasn't it? So I don't know if you want to talk about that a little bit.
Yeah, we decided just to look at that because it was the easiest one out of everything to sort of measure. You know, and slowly throughout the process we've seen an improvement in the compliance with it. We've got a mechanism in place to audit it. People review it on a daily basis to make sure it's correct. The ward clerks are fantastic because they're the people who basically run the show, don't they? And they're the ones who pick up any defects in it and so yeah, that was the one we focused on there. And I think we got to about level 4. You could correct me with that or I'm wrong with that one later.
I don't know why you're looking at me still. So we've just put a slide on here about the positive things that we've felt throughout this RPIW. And I've put staff engagement. Staff engagement appears both on positives and negatives. Obviously people are different and different people respond differently to change. But there has been some really good staff engagement throughout all of this, which has been really, really good to see. And I think the main thing is that there's been a big cultural shift in the perception of ward rounds and EDAM production. It's higher up on the priority list and it just is providing better outcomes for patients. There's been an improved relationship between the staff in crit care and the staff on the wards, and I think that's really important to team working. And I think, you know, when people get on, it's always going to be better for the patient as well. One more thing about the ward rounds that I didn't mention that I was supposed to is that we did take some qualitative data as well. So we'd been asking the staff to describe the ward round in one word, and prior to the RPIW it was chaotic, it was disorganised, and they were the words that people were using. Now consistently when I'm asking people, they're saying thorough, organised, I know the plan for my patients, which is great. So barriers, staff engagement. So, you know, there's always going to be people who are a bit more challenging, but it makes it all the more fun and hard work for us. There have been changes to the measurements, and I think that's been one tricky thing, especially with regards to the EDAM production. It just makes it that little bit more difficult to audit and show the work that we're doing, because there's definite positive change. Data collection is obviously difficult whilst we're all working clinically, but we've managed to get the data. Obviously we would probably like a little bit more, but we've just dealt with what we've got. My only other thing is that I'm wondering when I'm observing ward round if there's any observer bias, but that's something that I can't control. So perhaps moving forward we could maybe look at external people coming in and doing some observations for us as well.
Great work. Thank you very much. And as ever, we'll leave Q&A to the end now. I'm conscious of time because we've booked half an hour for this report out, and we've got a very important session coming up. So what I'm going to do is propose that we're going to present to our colleagues their certificates. We'll then hear from a number of them who've got things to tell us. If you have to go at one, that's fine. Just scoot off. But if you can stay, as I anticipate we'll go a bit beyond one, that would be great too. Okay? Is that alright? Fantastic. So, this is great because we've got 5 colleagues. Saida, who you'll hear from in a moment, Victor, Lorna, Mark and Sarah, all of whom are receiving their advanced lean training certification and offering some reflections. I mean, no mean feat, is it, this? It really is quite an achievement, and I think you all deserve our recognition and congratulations in terms of this. So I think what we'll do is if you all come out and we'll award your certificates. If you kind of line up here, that would be fantastic. So first of all, round of applause for Victor. Well done, Victor. Mark. Congratulations. Well done. Saida. Congratulations. Lorna. Congratulations. And where's Sarah's certificate?
Oh, just show mine. It was a joint effort. It's fine.
So Sarah, well done. Round of applause. We'll get that certificate. Okay. You have passed. Don't worry. So I guess just to say, I know a lot of work that went into it, but hopefully for all of you, a lot of learning, and we'll hear about some of that in a moment. And I know that we're going to hear a couple of presentations. And then we're going to hear from those of you in adult therapies as a group presenting together, which is great. So I always think as part of the Leeds improvement method, at the heart of this is the learning and is the application of the method to ultimately add value to the experience of our patients, our staff, our teams, and to work much more effectively, efficiently, reduce waste, and work with each other, obviously with the respectful behaviours that we know lie at the heart of this approach. And you've all done that tremendously and demonstrated that in the work that you've done. So I think from my perspective, really well done. I think we want you to encourage your colleagues, and I know you've worked with your teams when you've gone about this work, and hopefully some of that starts to spread and starts to get others more enthused about this approach. So very much looking forward to hearing what you've got to say. So I think, Saida, you're first up. Oh, yeah, let's do that. Yeah.
Julia, and I know that you always comment about the volume of work from your own personal experience. These people have done more work over less time, and they've got a requirement to be able to teach back the concepts as well. So this really represents a moment in time in our journey with the Leeds improvement method.
That's fantastic. Great.
Thank you.
Excellent. So, let's hear from you.
Okay, afternoon. I'm Saida. I work in histology, just downstairs actually, so I didn't have to come far. So my lean project was basically based on looking at the flow of precassettes, so mainly endoscopy biopsies that come into the lab. And it's from the dissection bench into the embedding centre out into the reporting side. So the bottleneck was how to get that flow streamlined out on the same day. So the endoscopy biopsies that we do come on a 2-hour schedule. So my aim was to try to get the work out efficiently, but in a predictable way, so I can manage the workflow. Okay, do I just press the screen? Next page. That's it. Thank you. So the key learnings. So basically, it's important to engage and involve as many staff members as you can. New ideas, try to implement or improve any changes that are good or bad. So I've done loads of PDSAs. Some were good, some were bad. Start with 5S. Important to clear all the rubbish, I call it, because once you've got that cleared, you can actually see a better picture of the workflow, and it eliminates the waste basically. And then I just sat back, watched, and did lots of timings. So that was quite fun. And then, importantly, make it quick, simple, and start with something small. So I just started with like a visual board, and then worked from there. And then think outside the box. And importantly, be patient focused, because the reason we're here is for the patient. So the challenges, probably like everyone else, was the time to do the project, time to actually do the normal work as well. The staff, trying to get everyone on board, resources, trying to work your normal duty as well as you're trying to get this implementation in place. Sustaining what you already have in place. So when I did my 5S project first, I had to make sure we kind of kept it clean. So I've established audits, and then we do those audit readouts in morning huddles. So that worked. Collaborating, so gaining as many people on board and let others drive it, so they take the responsibility, they feel ownership, and they kind of feel empowered with it, so it's like their project, not mine. And the next steps for me, obviously there is a bit more work I need to collect with the numbers that come into the processing room. But I've been moved into the main laboratory now, so I think I've got a new project, which is doing all again in the lab. So obviously I'm going to be looking at the bottlenecks, focusing on patient care, keeping 5S maintained and sustained, more visual controls, because I think that helps, having colour, pictures, everything, and most importantly, trying to meet the turnaround times. Thank you.
Maybe at the end. Thank you, Sarah. Great.
Thank you.
Victor, your turn.
Wow, okay, so buttons. Hello, my name is Victor. I'm a specimen reception supervisor from LGI. Last time I pressed a button, telepath crashed. Just kidding. Yikes. So, I think the ALT started for me at a really sort of nadir time in specimen reception. We were extremely short of staff, and it was really, really difficult to get the time to get away from the lab and do a lot of the work, and it was quite difficult to get the staff involved with what I was trying to do, because it was difficult for them to get time away from what they were supposed to be doing because of the staffing constraints. So anyway, challenges are actually nothing but opportunities, and I think we just chipped away at that, and we managed to sort of get the staff engaged, and once they actually saw what was happening, they could actually see the benefits of what we were doing. So it sort of went off quite well. So really, key learnings is, I think a lot of people allude to the fact that small changes can make a big difference, and it's actually quite true, and I think we've seen some real benefits from some of the small changes within specimen reception. But one of the key learnings for me was the 5S module. I think that was one of the most outstanding things that we'd achieved as part of this ALT. So I 5S the 24-hour urine room, and that was about 6 months ago now, and it's an absolute delight to be able to open that door and see it in exactly the same condition as it was when I actually set out and put it in place. So I think certainly from moving on and from part of my next steps are definitely going to be going to take on board more 5S, and we've got some real challenges at the old medical school in terms of 5Sing. So and other than that, my Lean for Leaders actually starts on the 4th of July, so I really but one of the actual bits of work that we did was on the referral section. So, and it was looking at the referral turnaround times of samples that we sent out to previous labs. And I did a lot of the product quality analysis and the level production based on the turnaround times of these tests. And we sort of went from, we were in a really poor position in terms of turnaround times. So the work that on the ALT course actually came in really, really handy. So I think here we go. Ooh, yeah. So and what I wanted to really show was the impact that it's actually had on some of our turnaround times. So you can see the gradual drop of how that has improved over the periods. So I've got and those eagle-eyed amongst you spotted the chromogranin A, which has gone up. We did some analysis on that, and we found out that there was actually 2 lost samples that we, not from our end, I hasten to say, but because of that, that had actually increased. And the TGN, which is slightly different, but the turnaround time on that is only 7 days anyway, so the fact that it's setting at 8 is pretty good. So I think that's probably one of the greatest successes. Anyway, I'm not real good with speeches and I'm less good with praise, but I am okay with gratitude. So I would like to say thank you to the KPO team for all their help and support, and to my colleagues in adult therapies who adopted me, sort of, allowed me to work with them, and to Ellie McLaughlin, who did a lot of work compiling all the figures for me for these turnaround times. Thank you very much.
Thanks very much, Victor. It's great to hear that. And in fact, you'll recall, I think, the number of times you've shown me around your empire down at the old medical school, and we talked about some of those challenges, but seeing you apply this to the work and looking at even within the constraints of the old medical school is fantastic. So it's great to see. Right, we've now got adult therapies team, Lorna, Mark and Sarah. Over to you.
Okay, good afternoon everyone. My name's Mark Smith. I'm the orthotics manager based mainly at Seacroft, Specialist Rehabilitation Department there. So alongside my colleagues Sarah and Lorna, we're doing a joint reflection on our adult learning, our advanced lean training through the KPO team, and where we've been and where we're going to on that journey. So it was really clear from the outset and throughout the round about 6 months training, everything that we're doing was focused around the patient's needs. Like Victor and Syed said before, it was really clear that everything that we're doing had the patient at the heart of it. You know, one of the main Leeds values. So it was very clear that that's what we're working to, and everybody in the organisation will always tell you that they are working for the patient. So I think what this course kind of helped us explore a little bit more about exactly what the patient needs, and what is valuable to them, and what is non-value. So that's the kind of level that hadn't really been delved into before throughout the organisation in my eyes. So using the lean methodologies that have been evidence-based throughout industry, turning that into a healthcare system and looking at value and non-value added, it seemed a very sensible thing to do. So we looked closely at this value and what was non-value, and really how we try and cut down on that non-value side of things, eliminate it when it was waste that was not necessary for the system, or reducing it if it was necessary waste. And then we sort of mapped these value streams and how it would again sort of work better for the patient. So there was a lot of observation, as we've heard before. A lot of before the sort of lean training, you would do process maps, a lot of different tools that would let you look at a service. For me, the difference in this was really being much more on the shop floor, not sitting around the desk with people, is engaging exactly with the process, and again having the patient's eyes when you do that, and also using respectful behaviour. So you may be making some challenging statements, It's just making sure you do that in the right way. So we also explored the demand on our services in great detail, much higher level detail than we have before, and looking how we can look to create flow in our systems that pull from the patient demand, rather than what we commonly do at present is just work off our capacity and not really in depth to what our demand is. So through all this, really, it's just taught us, and again, like Victor said, it's about little steps, small incremental change that we can go through this teaching method to make some continuous improvement for the services that we provide. Okay, so that's the kind of key teaching that I've taken from it, and we've discussed it with my team, and I'll pass over to Sarah.
Hello, my name is Sarah Wright. I'm Occupational Therapy Clinical Service Manager at Chapel Allerton Hospital, and I'm going to talk about the challenges and the barriers that we have identified throughout the course. And the biggest one, it's been alluded to already, is definitely time. Like Helen said, there's a lot of work. We've got 12 weeks. It was over winter for us, so we did our first course at the end of November. We had 12 weeks to do our homework on the Gemba and then take it back, which then obviously covered the winter pressures time. But we've identified that probably no matter when we did it, whenever that 12 weeks was, there was going to be pressures. If we'd done it in the height of summer, we'd have had staff on annual leave, so that was always going to be an issue, I'm sure. And by nature of the fact of the work that we were doing, like Mark said, we were doing it on the Gemba, we were doing it with our teams in the workplace. So we're really lucky in adult therapies. Our senior managers are all on board with Lean. They, gave us time, allowed us to block time out to do this work. But by nature of the fact that you're there, you're on the floor, you're doing it with your team, real life takes over, and maybe not all the time that you put aside can then be used. So there were real time pressures there. So it was really important to keep the scope of what we were doing small, and again, the others have alluded there to how important it is to have your team engaged and team commitment and following through on your commitments. And again, Victor mentioned this, it's more of an opportunity than a challenge, because we are very lucky. We've got an engaged workforce in adult therapies. They all want to do this work. So sometimes it was more about containing the ideas and trying to explain to your team that yes, we can go forward with this, but not just yet, because I've only got 12 weeks and I've got 10 pieces of homework to do. So it was more about saying we'll come back to this later and move things forward when we've finished this 12-week course. I'll hand you over to Lorna, who will talk about the future.
So, my section in this talk is to look at the steps that we had immediately post homework, and also the steps going forward into the future. So my name's Lorna Williams. I'm the Clinical Physiotherapy Manager for the Musculoskeletal and Women's Health Service. Therapists, by their very nature, as Sarah's already alluded to, are really quite engaged. They're problem solvers, and they have an inherent ability to actually identify things within improved service delivery that needs improving in, or patient care, and they see it and they just do it. And I think what we're not so good at is actually measuring that change, or actually letting others know about the change via more formal means. We just let it seep. So that's definitely something that we need to actively encourage our staff to do in the future. At a more local level, our immediate next steps have taken different routes. We're a cross-section of professions, and therefore the next steps have needed to suit the different services and also the different needs of the teams. One example, though, is for Sarah and I, where we focused on working with colleagues at Chapel Allerton to actually establish a local Leeds improvement, or a LIM forum. We're working together with a cross-section of professions, including admin, and we have big ambitions to improve patient flow at Chapel Allerton outpatients. Less formal routes, Julian alluded to this. What we found actually is that there's been a lot of more informal routes have happened, where some of the work that we've undertaken, the staff have actually shared those ideas between them, and what they've done is across professions, it's become evident that they've actually just word of mouth has meant that they've started to implement some of these ideas themselves. And then actually when you look at it, not only have they implemented it, but they've improved on the work that we'd already done. Darn. and they've done a really good job at it as well. So we need to use our newfound knowledge to support them, to encourage them, to guide them and to nurture them on their newfound Leeds improvement journey. So going back to those next steps for the future, it's early days since we finished our training or our course. We recognise that those steps also need to include developing and establishing a shared purpose and a vision for our team and for our wider CSU, so that we can actually engage and inspire those and take them on that journey that we've got the enthusiasm for, so that our enthusiasm will rub off on them. And I think that's already happening, but maybe we need to give that some serious thought about formalising that a little bit. Finally, because I'm sure I'm over my 2 minutes, but to quote Richard Branson, don't think about the cheapest way to do it or the fastest way to do it. Think what's the most amazing way to do it. I suspect that teams across adult therapies may just have some amazing things to offer when you see our next steps. Thank you.
Well done. That's excellent. Thank you so much. Brilliant. Before you sit down, Sarah. So, many congratulations. That's great. So, fantastic. You've heard this lunchtime then from an update from critical care and neurosciences from Steve and Katie, then fantastic work from our advanced lean training participants, and thank you for doing some presentations and your own reflections. I know it does take some nerve to come up here and report back and talk about that, so well done, and you've all done some great work. So questions, 5 minutes maybe, and then I'll make sure we close. So any questions, comments, feedback from everything that you've heard this lunchtime? Is that then Helen?
Well, just congratulations to the advanced lean train people, because I know that that's a huge amount of work, and I also know from, you know, hopefully supporting Helen and co through the training that it's no mean feat, and I think that you've all presented really, really well, and I want to come and have a look at that 24-hour urine room. And then I had a question really, which was for Katie really, about, I know because there will be variation amongst the consultants who are leading the ward rounds, and I wondered about how, have you had any great ideas about how to feed back to them the variation?
So what we tried to do initially was create a standard work for the ward round in terms of things that would be discussed and what would be looked at for each patient. So that's what we try and stick to, and that was what the specific job role allocation was for. So there still is variation, and it tends to be in relation to the time frame that they've got to do the ward round rather than anything else. So that's what we still need to work on really.
And but that's really good to hear, because I think we can all understand varying time constraints. What I would have been upset to hear was that some people really weren't engaged in this work and hadn't recognised the benefit of it to the patients.
Yeah. No, I think everyone has.
Brilliant.
Right.
Thank you.
Great. Thanks, Helen.
It was just a comment to Katie and Steve. The theme running through that work is how much time we plan to do something and how much time it actually takes, and that, for I know for my advanced lean colleagues in the room, is about the waste of unreasonable expectations. So, and you've really been exploring how long it actually takes to do work and take waste out of that process. So absolutely well done, and I genuinely really appreciate your candid openness and honesty in the challenges that are, you know, working with large teams of people to improve. So please keep being speaking the truth about what's going on, and I genuinely can feel the hope from you about this continuing to get better. So well done. To my Advanced Lean colleagues, yes, I am so proud of all of you. I know how hard you've worked over some really challenging, not to underestimate the challenges that you've had. You have other colleagues in the audience who are going to follow you in forthcoming weeks who've come to see how it's done. The other fascinating thing about having been on all your Gembas recently to see the fruits of your work is this work is clearly embedded. Your teams are enthusiastic about it, and they are, as you say, they are improving it for you. And what you're also realising is when you create a standard, you just surface more problems to sort out, and you're all working with that in terms of part of your moving forward. So absolutely well done, and thank you.
Right. Simon.
Just an observation, so massive well done to you guys for sorting out adult therapies. I think the thing from today, especially in our value stream, is around that actually it's okay to stop and take stock of things, which is what your report out has been, and not just charge on because it feels right. And then we've got a newer RPIW which we reported on last week, which was as a result of some of the things from that actually stopping from it. And checking the progress, and it's obviously doing what you've done as well. But it doesn't always feel comfortable to do that.
Absolutely.
And we reached that point in December as a value stream. So
Yeah.
well done.
Perfect.
I just wanted to make an observation a little bit along with Simon there, but something that I'd like to share that this particular Advanced Lean group did was they actually set up a homework group, which was at 5 o'clock on a Tuesday. And I'd be down the corridor trying to work, and there'd be loads of laughter going off in another room. But that was their support mechanism, and I think that not to underestimate them getting themselves together to do the stopping of each other when they're realising that they were too wide, rather than not being able to go too small so they could go really getting deep. But I think that was a really positive step forward. The KPO team were brilliant. They came along at that late hour and sat with them until that finished, and sometimes it was quite late, wasn't it, guys? You'd have just kept on that. But that was another really good mechanism, and it is about relationships, people supporting each other. Lovely to have Vix joining our adult therapies as well. So it's and that really was a good model, I think, for moving forward. And I think I would recommend that for any of the cohorts going together, is having that pull together. It naturally happens, I think, in the cohorts. You have your buddy, but I think it worked really well because a lot of you all came together.
Thanks, Janice. I can see a lot of nods to that point, and I think that's, as you say, a key part of how we get the best out of it. Great. Okay, that's time. I just want to say thank you to you all for staying and listening to that. Particularly well done to everyone that's reported out today. Great work. And I've found that really inspiring. I hope you all have. It just kind of gives us a really great sense of the possibility and achievements that we can deliver for our patients with this approach. So let's keep it going. Well